Once again, good morning, teachers, senior colleagues, and colleagues. We shall be taking the last two questions left for November 2021. We start with question number 10 by Dr. Indunuka Ijoma. I don't know what's happened with her.
No, I'm going to reshare it now. I don't know what happened.
Okay, no problem. We can't hear you, but we can see your slides.
Can you hear me now?
Yeah, we can hear you now.
All right. So can you see my slide and hear me?
I can see your slide, please.
All right. Good morning, senior colleagues and colleagues. This morning, I'll be attempting question 11. And the question says, data collected by pharmacists to determine if drugs were being dispensed appropriately, and feedback data also collected from the patient's relatives. First question is, would you require ethical clearance? Give reasons. The second is, give 4 scenarios in data collection that involve patients but do not require ethical clearance. 3, give 4 parts to domains of ethical clearance in obtaining consent. And 4, differentiate between assent and consent. So would you require ethical clearance? Give reasons. Yes, I would require ethical clearance. And my reasons include, first, to promote the aim of the research. The pharmacist is attempting to collect data from human participants, and she needs to promote the pharmacist needs to promote the aim of the research, which is to have knowledge about how the drugs are being appropriately dispensed, the truth about the process, and to avoid error. It's also important to get ethical clearance to promote the values essential to collaborative work, such as to build up trust and accountability and mutual respect and fairness with the participants. This will also ensure accountability of the researchers to the public when an ethical clearance is gotten. And this is with respect to federal policies on research misconduct, conflict of interest, and protection of human participants. Ethical clearance is also important because it will help to build support for research, and people will likely fund the research projects if they can trust the quality and the integrity of the research. It will also promote other important moral and social values, such as social responsibility, compliance with law, and human rights, public health, and safety. Secondly, it's important that an ethical research is gotten because there are several standard codes with stipulated guidelines on research. In Nigeria, we have the National Health Research Ethics Committee, and others will include the Nuremberg Code, the Declaration of Helsinki, the Council of International Organizations of Medical Sciences, the Northfield Council on Bioethics, and others. So any research that will involve collecting data from people that can range from taking blood, physical tests, interviews, observation, or answering questionnaires will require an ethical approval as stipulated in these guidelines. And then research must also be conducted responsibly and professionally, using the 4 major principles of beneficence, non-malfeasance, justice, and autonomy. Beneficence is that the researcher has an obligation to be of benefit to the participants. Non-malfeasance, the researcher has an obligation not to cause harm or incapacitate the participants. And justice, there has to be equal care for all participants, regardless of their social, cultural, economic, or gender differences. Based on the principle of autonomy, every person has an intrinsic and unconditional worth, and they have the power to make rational decisions and choices. So they have the power to exercise their capacity for self-determination. And so this will enable the participants to, improve the aspect of confidentiality when they're allowed to exercise their power of self-determination. There will be confidentiality, truth-telling, and informed consent. The second question says, give 4 scenarios in data collection that involve patients but do not require ethical clearance. First is, from what I could gather, first is literature reviews and meta-analysis. These are analysis of existing published literature. They do not directly they do not involve patients directly or humans directly, but these are existing data that already in the public domain. So literature reviews and meta-analysis is one scenario where data can be collected without that involve patients and will not require ethical clearance. Another is case reports and case series. These reports, they describe the clinical presentation and management of de-identified individuals. And there's no, these individuals are anonymized. So there is not really a scenario where ethical clearance may be required. Another scenario is when a secondary data is collected and analyzed. These studies, they utilize previously collected or publicly available data, such as government reports, census data, fact sheets, or other open source data. And fourthly, interviews or surveys conducted with public officials or experts in their professional capacity without the need to collect personal information. These are some scenarios where ethical clearance may not be required. And the next question says, give 4 parts or domains of ethical clearance in obtaining consent. There are about 5 of them, and the first is competence. The participant has to have the capacity to understand and decide. And secondly, there has to be a full disclosure by the researcher. Every medical information has to be made available so that they can have a good understanding and be able to make rational choices. And then the participant has to have a full understanding of the disclosure made by the researcher. And fourthly, there has to be voluntariness. The participants they will not be coerced into the project or the research. It has to be a voluntary action on their own part. And then also the consent to the proposed action. The next question says, differentiate between assent and consent. Assent is the agreement of someone not able to give legal consent to participate in the activity. Like working with children or adults not capable of giving consent, it requires the consent of the parent or legal guardian and the assent of the subject. So the assent comes from the one who is not able to give the legal consent. So it's applicable to participants that are lacking capacity to give informed consent. And then the process involves making sure that the intended participant understands the research to the extent possible and understand what it means to participate. The process will also ensure better participation and protect autonomy. According to the Bioethics Society of Nigeria guideline for young persons' participation in research, a consensus statement in 2014 includes the age ranges for therapeutic research. Those that have been graded as minors are 9 years and below, and will be requiring only parental consent for such participants. Adolescents aged 10 to 15 will require both parental consent and assent from the adolescents, while young persons that are aged 16 years and above can give consent by themselves. But if it is a non-therapeutic research, minors 9 and below, only parental consent can be gotten. For adolescents 10 to 12, parental consent and assent of the adolescent. Then for young persons 13 and above, they can give consent by themselves. And they defined an adult as an individual more than 16 years of age. So consent can be defined as an instrument of mutual communication between doctor and patient with an expression of authorization, permission choice by the latter for the doctor to act in a particular way. And it could be verbal or written. Verbal, like during routine vital signs check by the nurse. A verbal consent is usually given, or when a doctor is doing a bedside examination, a verbal consent is given by the patient. And it could be written when procedures or other interventions are about to be undertaken. So the consent must be obtained from all conscious adult patients who are capable of taking an independent judgment or decision, or emancipated minor. An emancipated minor is a minor that assumes the role of an adult as a result of their social or cultural roles, such as an example is a girl of 14 years who is married and has a child. She can be regarded as an emancipated minor. An assumed consent. This entails the doctor carrying out an intervention or giving treatment that he or she assumes the patient would have given if he or she were not incapable. An example is taking an unconscious patient to the ICU for critical care, but this also has a clause to it. If the patient initially has a directive such as do not resuscitate, that will be respected if such is available. Thank you. This is the end of my presentation. Thank you very much.
Thank you, Dr. Injenuka, for this amazing presentation. It's actually a very good one. You must have consulted several sources to gather this beautiful information. Thank you very much. The floor is open for contributions. So any contribution? Okay, Dr. Mamoudou is thanking you for this beautiful presentation. Dr. Cassidy also is thanking you. And I don't know, maybe I just have something. Please, can you highlight those ethical the reason why you need to obtain ethical clearance, please? Sorry. Okay. All right. What are the other reasons?
The second one is, according to this stipulated guidelines.
Okay.
Have
Thank
to
you.
abide by stipulated guidelines.
Thank you very much. From the chat box, Dr. Ekele Robert also thank you for this beautiful presentation. Okay, our Chief Remy want to contribute. Thank you, sir. Go ahead, sir.
All right, thank you. Thank you, Januka, for the beautiful presentation. I think it was well done, well researched. But please, don't forget about clinical audits. When you talk about situations where you collect data without requiring consent, it's an important omission. Please never omit it. It's usually one of such situations where you can collect data, okay, without requiring consent. Okay, so I think that's what I noticed that you omitted. Well, I can't remember. If I remember any other thing, I'll say thank you.
Thank you, sir, for the contribution. We appreciate, sir. Any other contribution? Okay. The second presenter can start preparing for sharing his slide.
Okay, Chief, I had some challenges. I couldn't work on slides, but I wrote out the answers to the questions. Maybe I'll just answer the questions. I'll put the slides later before the week runs out. Let me look for the question.
The questions can be put up and then you now answer it.
If you can put up the question, I'm actually looking for the question.
Oh, can someone help us reshare the question?
I'm trying to look for where that question is. I'm looking for that question. Okay, I think I've seen it. Let me post it to the group.
Okay.
You have posted it. No one can share. I'm using a different device to present.
Okay, please, can someone help share the question? Dr. Mahmoudi, can you help us share the question, please? Dr. Kasidi, Dr. Mahmoudi, can anyone help us with the question?
Master, read it. The question is not
Answer the question.
Yeah.
You said it on the page.
It's in the platform. Dr. Dalatu. That's question 9, right?
Yeah, question 9.
Yeah. Okay.
You can go on.
Yeah.
So the question is
Thank you. But can you enlarge it small? All right. It's okay. Thanks.
You're giving a patient that has been passing stool profusely. List 4 symptoms of dehydration and 4 signs of dehydration. The signs will include dry oral mucosa, sunken eyes, decreased skin turgor, decreased capillary refill time, hypotension, tachycardia. That's postural hypotension can also occur. Then the symptoms will include thirst, weakness, lethargy, reduction in urine output, fatigue, confusion, dizziness, and in some extreme cases, syncopal attacks. Said name. Okay, no, sorry. What are the causes of diarrhea with fecal osmotic gap of greater than or equal to 50? Some of the causes include laxative abuse, magnesium overabuse, carbohydrate malabsorption, pancreatic insufficiency, chronic mesenteric ischemia, celiac sprue, chronic pancreatitis, lactase deficiency, Whipple's disease. Then the other question is mention 4 features of infective diarrhea. Patient could have abdominal pain, blood in stool, fever, and presence of mucus in stool. Outline 8 treatment plans. 8 treatment plans. First of all, you have to admit patient, resuscitate, do ABC of resuscitation, then fluid therapy, antibiotic therapy where it's applicable, electrolyte replacement, and then general supportive care, and then avoid precipitants, food hygiene, and of course, treat complications if any. So that's all. Hello, sir.
Okay.
True.
Thank you, Dr. Agu. Thank you. It's time to entertain contributions, comment, clarifications.
Hello?
Good. Yes, sir.
Yeah. I just want to put this on the record. Who is the doctor that presented? What's your name, please?
Okay, so my name is Dr. Agu.
Dr. Agu, okay. Dr. Agu, we actually expected a PowerPoint, and we expected you to talk to us about either osmotic diarrhea, talk to us about diarrhea, the different types and all that. That should be in the PowerPoint, okay? It's fine that you answered the question, but we expected a PowerPoint from you. Okay, so we're hoping that quickly, very soon, you give us the PowerPoint. But it's okay that you answer the question. But I want to put it on record that this is not what we do, and it's not completely acceptable, but we're going to accept it today. Please, others, prepare your PowerPoints, I beg you. Okay, we can go on. Thank you.
Okay. Thank you, sir, for coming in. Thank you. So any other comments? Okay, maybe I will just ask my Dr. Agu, please, I have a question.
Okay, Chief, go on.
Yeah, I don't know what's responsible for this high osmotic gap of more than 100 milliosmol per kilogram. Is it specific to some form of diarrhea, group of diarrhea, causes of diarrhea, or it just can occur in mix with other causes?
I think the basic thing there is the presence of osmotically active particles in the bowel. You know, like, for example, in a patient that has carbohydrate malabsorption or maybe deficiency in the enzyme, those particles can pull water into the lumen. So, you know, what differentiates them from the, I think the infective one will be the presence of these osmotically active particles, which end up pulling water, you know, and other electrolytes as well into the lumen, you know, which will eventually result in the diarrhea that we see in this type of, you know, diarrhea. You know, so those osmotically active components, you know, will be the reason why the fecal osmotic gap will be greater than 50. I think
Sorry,
that's
Dr.
what I can.
Hello?
Yes, sir.
Maybe you could start by telling us what osmotic gap means. What is osmotic gap? How do you calculate it? Thank you.
Okay, Chief, I will have to check. I don't have those information offhand. I will have to browse it or check it. Maybe I'll put it in the presentation. I'll put it in the presentation.
No, that's okay. But if any other person here has an information, the person can give us. Thank you.
Okay. My next contribution again is this is a diarrhea, and we are asked to mention, outline a treatment plan. I don't know whether you emphasize more on the electrolyte, because most of these diarrheal diseases, they come up together with electrolyte abnormalities. So one of the outline is looking for those either to prevent them or to treat them if they occur. Then adequate nutrition is also very important in a patient that have diarrhea, and sometimes supplements, even though it's more in line in pediatric, but even in adults, is advocated. Some of the supplements like zinc may play a role. And for some of the causative agents, vaccination is also very important. When somebody has diarrhea, if causative agent has a vaccination, there is a role to vaccinate, especially if the cause is a public thing. Then health education, I think they should also be part of the steps. But again, we have to highlight the acute treatment first. Maybe subsequently, when patient improved, you have to give me. It could just be that improvement in personal hygiene and other things that affects that may worsen or cause the diarrhea. And these are some of my comments.
Thank you, Chief.
Yeah, in the chat box, Dr. Jibola Sanders said, kindly outline your steps of management again, and what fluid will you prefer? I think people will have been appreciating if you tell us each of the highlights. Okay, I would like to dissociate my patient with IV fluid, maybe using this as so this as while monitoring that. I think that was what some other colleagues expected.
Okay.
So Dr. Jibola Sanda said, outline your steps of management and what fluid will you prefer?
Okay, the fluid I would prefer maybe normal saline or Rengas lactate. If Rengas lactate is available, fine. And then normal saline. Those two will be the preferred fluid. And then the steps of management: admit patient, do ABC of resuscitation, then fluid therapy. The fluid therapy will be the one I just mentioned, antibiotic therapy where appropriate, electrolyte replacements, especially the potassium. Potassium, they usually have hypokalemia, so you may need to replace the potassium. It's a calculation on how to replace it. I don't have it offered. I'll add it in my slide. Okay. And then general supportive care, avoid the precipitants, food hygiene, health education, and that's all I listed. I just listed about 8 or so. And I had some challenges this past week. So
we know you presented 2 days ago. You presented your book.
Yes. And to be very honest, I didn't sleep for several. In fact, right now I'm having some serious headache. That's why I didn't even do this thing.
All right. Another from the chat said, "Good morning, everyone. Thank you for the presentation." Okay, it's also asking about how do one calculate fecal osmotic gap? What is normal range? So I think that just to emphasize
I'll add it in my slide.
Hello, good morning. Good morning, everyone.
Good morning.
Okay, well done to Dr. Agu. But as we had earlier told you, we really would appreciate if we can all, coordinate ourselves, because the topics are usually shared almost a week before presentation, so really do not wait till it's a day before you start working on your slides, because if memory serves me right, you've also done this in 1 or 2 presentations in the past. So so that you will not be known to be a last minute person, please. So it was a very good attempt, for seeing this, and then sorry for your ill health, and I wish you speedy recovery. So please try and take care of yourself, because the exams are, by the corner. So when we talk about diarrhea, apart from the definition, knowing that is increased liquidity of the stools, and when you have, and also increased bowel movements, the frequency of bowel movements, usually more than 3 times a day, or the stool with more than 200 grams, or a stool that can consistency that takes the shape of the container in which it is passed into. So the small intestine, and the colon are highly effective in reabsorbing water. So about 10 liters of intestinal fluid are usually absorbed on a daily basis. And when you don't have you're having issues either from the small intestine or from the large intestine in terms of fluid reabsorption, then diarrhea would occur. So we know that there are different types of classifications of diarrhea based on the duration. So we have the acute diarrhea. Sorry, there's a shrill noise. Dr. Agu, please, can you mute yourself? Thank you. It was distracting me. So acute diarrhea is when the diarrheal illness has lasted less than 2 weeks, and occasionally it may persist more, but then we now have the persistent diarrhea between 2 weeks to 4 weeks, and then anything above 4 weeks is regarded as chronic diarrhea. And then diarrhea too can be divided based on the pathophysiology and of the causative process. And that's when we are now talking about osmotic diarrhea and secretory diarrhea. So apart from that, you can also have inflammatory diarrhea, steatorrhea, dysmotility or functional diarrhea. So the difference in classifying diarrhea into osmotic or secretory diarrhea, we use the fecal osmotic gap, or the stool osmotic gap. So the formula is a constant, 290 is a constant, minus 2 times the sum of the stool sodium and the stool potassium. So 290 minus 2 into bracket sodium plus potassium. 290 is a constant minus 2 times the sum of the stool sodium and potassium. So that is the formula. So for osmotic diarrhea, we should know that large amounts of polyabsorbable solutes, within the intestinal lumen will cause an osmotic, will cause retention of water in the stool. And sorry, I received a phone call, please. Can you hear me now?
Yes, ma'am, we can hear you, ma'am.
Yes, ma'am, can you?
I'm so sorry. It was a phone call. I had to tell the person to cut. Okay, so osmotic diarrhea, what's one of the things that differentiates it from secretory diarrhea is that when you stop eating or you fast, so to say, there will be cessation of diarrhea, and also osmotic diarrhea has an abnormally elevated stool osmotic gap that is greater than 125 milliosmoles per kilogram. So now that 290 that I mentioned, that is a constant, is actually the normal serum osmolality of the body. So the body maintains the fecal and serum osmolality at approximately 290 milliosmoles per kilogram. So that is why that is a constant, So when you do that calculation and you get your result is less than 50 milliosmoles per kilogram, is considered normal, and then if it is between 50 and 100, that now refers to secretory diarrhea, and then greater than 125 milliosmoles per kilogram is consistent with a pure osmotic diarrhea. So less than 50 is normal. Then for secretory diarrhea, we have that the intestinal secretion overcomes the absorptive capacity of the small intestine and colon. So it's where there's an imbalance between what is being secreted and what is being reabsorbed, and secretion of incompletely absorbed electrolytes leads to retention of intraluminal water, and the diarrhea will continue irrespective of cessation of eating. So whether you fast or not, the diarrhea will still continue, and the patient pours out large amounts of fluids in a day, almost like up to 1 to 10 liters of fluid, and the osmotic gap, is almost near normal. The fecal osmotic gap is near normal, just as I mentioned to you. So that's what will tell you that this patient most likely has secretory diarrhea. And there are different types of causes of both the secretory and the osmotic. So osmotic, usually when you are taking a history, is in the history that can guide you to the likely etiology. So when patients are taking medications, such as lactulose, antacids, sorbitol, laxative abuse, this suggests that the cause of the diarrhea is likely osmotic. Even when they have carbohydrate malabsorption, lactose intolerance, those who are lactose intolerant, and then also high ingestion of sugar substitutes like fructose, those are lactose intolerant. So these are the causes of osmotic diarrhea. Then secretory diarrhea are so many, most especially a lot of infective causes. So even you could have medications, osmotic laxatives. You have stimulants. So those who use stimulants, abuse stimulants, can have secretory diarrhea from it. Then bowel salt induced diarrhea, colitis, inflammatory bowel disease falls under this, diverticulitis. Then also bacterial toxins. So most of these infective processes. Then neuroendocrine tumors too can cause that. Then endocrinopathies from Graves' disease, so hyperthyroidism, diabetes mellitus, Addison's disease, hyperparathyroidism, and then other, even HIV, lymphomas, colorectal cancers, inflammatory bowel disease. All these are well-known causes of secretory diarrhea. Okay, so let me look at the questions. So I think we have mentioned symptoms of diarrhea and signs of dehydration. Symptoms of dehydration and signs of dehydration, because that's very important. I think there's a table in Kuma and Clark that clearly outlines that. So the signs are usually more florid in children. So where you see the depression of the anterior fontanelle, sunken eyes, but I don't think they're that so florid in adults. But there's first of all, there will be excessive thirst. The patient can be disoriented. Then there will be loss of the skin turgor, and the mouth will be dry, the skin will be dry. Then even in terms of signs, you will have tachycardia. Then there will be reduced urinary output. So you have to measure the urine output, because of course the body won't want to be losing more fluids. So the patient is prone to developing acute kidney injury. So remembering all that, and then of course management of the patient is because of the level of dehydration, which should be calculated, and then the investigations that are done. So when you are managing these patients, you have to think of the resuscitation, the ABC of resuscitation. in this patient, and then knowing that the patient has lost a lot of fluid. So usually the physiologic fluid that is used in rehydrating patients is in normal saline and Ringer's lactate. And then also, if this patient can take orally, oral rehydration solution. I didn't hear you mention ORS. You can't manage diarrhea without mentioning ORS. So we have the WHO. There are some things I can't remember now. So I know that the WHO solution there has the amount for sodium, potassium, chloride, and all that. And then the oral rehydration solution. Used to be two beer bottles of water that's about 600 mils with 2 level teaspoons of salt and then sugar in the ratio. So you should also go and familiarize yourself with how to constitute ORS, because it can be asked. It's not everybody that can afford to buy the ORS sachet, so you can also constitute it at home. So you have to note that.
I think it's 2 to 10, Chief. 2 salt, 10 sugar, something like that. I think so.
But let us also familiarize ourselves with it. Thank you very much. But it's very important. We must hear that ORS. Once you mention diarrhea, ORS, and usually is given when the patient can still take orally. Because if this patient comes and is already comatose, you can't give ORS. That's when you now start giving parenteral fluids. But if this patient can tolerate orally, then ORS is the way to go. And then also teaching them personal hygiene and all. And zinc is important because zinc helps in reepithelialization of the villi, and also it also helps in reabsorption too. So zinc is also important in them. And then depending on the investigation that you've done, if there is an infective process, then that's when you give antibiotics. But remember that it's not all cases of diarrhea that is caused by infection. And then if you're evaluating, don't forget HIV tests in these patients, and and also look for endocrinopathies. When we talk about hyperthyroidism, can be with, and then of course, as we had earlier mentioned, calculating the fecal osmolar, the stool osmolar gap to help you know which is which. Then measuring the urine output when you are rehydrating a patient. So that's what you use in knowing whether this patient is recovering because of the risk of AKI. And also too, in chronic diarrhea, that's lasted more than a month, there's a room for colonoscopy in those patients. So also know what is going on. So I think if I remember any other thing, I'll add it. Thank you very much.
Thank you very much, ma'am.
We really appreciate your vast of experience and the contribution, ma. Thank you very much. It's clearer with your contribution. Thank you, ma.
You're welcome.
It will entertain more if we have there is any other thing. And before any other thing, I still want to remind our colleagues that have presented before, but were yet to post their presentations. Please, they should kindly do that. It's going to be important for some of us during our revision. Please. Thank you. I think I'll hand over to Chief Dr. Christabel.
Okay,
Good
sorry,
morning,
Dr. Yaya, we have finished the questions.
Sir?
Have we finished the question?
Yes, sir. We finished this his question.
Oh, okay.
Yes, sir.
Thank you, Dr. Yaya. I want to thank the presenters today and thank our dear Chief Cookie for coming to the rescue for the second presentation. Thank you so much, Ma. We appreciate you. I think all I want to say, Chief Cookie and Chief Remigus have talked about